Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from SIGAN.
This program is presented by Medscape Education Global.
Hello, I'm Erik van Kutten, Professor of Medicine at the University of Leuven in Belgium, and welcome to this program titled HER2-Positive Metastatic Colorectal Cancer, Unraveling the Game-Changing Treatment Approaches. Joining me today are Chiara Cremolini, Professor of Medical Oncology at the University of Pisa in Italy, and Frédéric Penot-Lorca, Professor of Pathology and Head of the Department of Pathology and Human Biology and the CEO of the Cancer Center of Clermont-Ferrand in France. Welcome, Chiara and Frédéric. In this activity, we are going to discuss the role of HER2 as a biomarker in metastatic colorectal cancer, and also the best practices for testing for HER2 overexpression and amplification. And we will then discuss some of the key trials investigating therapies targeting HER2 in metastatic colorectal cancer, followed by a case example, so that everybody can understand how we can integrate our knowledge best in clinical practice today. So let's first discuss the role of HER2 in metastatic colorectal cancer. HER2 amplification and overexpression is established as a targetable biomarker in breast cancer and gastric cancer, and also we have some data in some other cancers. The role of HER2 as a biomarker for prognosis in colorectal cancer, however, remains a little bit uncertain and unclear. And also the role of targeting HER2 as a biomarker for new agents, although not completely established, we are seeing more and more data in this setting. HER2 overexpression and amplification in patients with RAS wild-type metastatic colorectal cancer is also associated with resistance to anti-EGFR therapies. And therefore, it's important that we can discuss this more in detail. And therefore, Chiara, can you describe us the role of HER2 overexpression and or amplification in metastatic colorectal cancer?
Well, Eric, I guess that we were quite jealous of clinicians, colleagues that are facing breast cancer and gastric cancer, where actually the role of HER2 as a biomarker is well established. But now also in metastatic colorectal cancer, we have some important information about this biomarker and its potential usefulness in the daily management of our patients. As you mentioned, HER2 amplification or overexpression may be a predictor of resistance to anti-EGFR agents. And although we do not have a prospective confirmation of these suggestions from retrospective evidence, and I guess we will not have ever a higher level of evidence about the predictive role of HER2 amplification with regard to anti-EGFRs, still I do believe that it makes a lot of sense not to use anti-EGFR based regimens, at least upfront, in patients bearing HER2 amplified metastatic colorectal cancer. But now we also have data about the role of HER2 as a targetable alteration. And also according to the ESMO scale of clinical actionability of target, it has a high level of actionability thanks to the evidence collected with several anti-HER2 strategies. So I do believe that this is a marker that needs to be tested and implemented in the management of metastatic colorectal cancer patients.
Yeah, these are some important points, Chiara, but this, of course, leads to the question, and that's for Frederick, on how we test for HER2 positivity, because that's the starting point. Do we test IHC? Do we use FISH? Or how do we test that, and what are the criteria for having a positive tumor?
Thank you, Eric. Um, First of all, I would like to give a kind of overview of what do we need in colorectal cancer as biomarker. Um, we need to have the MMR MSI status for all patients with newly diagnosed colorectal cancer by immunohistochemistry plus minus PCR. Of course, we need to have KRAS, NRAS, and BRAF. And HER2 or HER2 testing is important, as Chiara mentioned, especially in the case of wild type RAS and BRAF. So for those cases, we will need HER2 by immunohistochemistry in situ hybridization. Maybe we can discuss also molecular biology like NGS or liquid biopsy. We have another biomarker, NTRK gene fusion, but it's extremely rare in colorectal cancer. So if we don't have access to NGS, it will be immunohistochemistry with a confirmation by molecular biology or in situ hybridization. So if we go to HER2 scoring in colorectal cancer, as in breast or gastric cancer, the scoring is performed by immunohistochemistry. But from the Heracles trial, we know that the scoring has to be different from the scoring in breast or gastric cancer, and the cutoff for positivity is not 10%, but it is 50%. So as you can see on the right, the scoring 3 plus is really intense, complete, or basolateral membranous staining in equal or more 50% of tumor cells. On the opposite, when we have no staining at all, it's score 0. We have the 2 plus when we have a moderate staining in more or equal 50% of the cells, or if it's not a 3 plus, so the staining is really intense, but it is in less than 50% of tumor cells. 1 plus is when we have a faint staining or a moderate staining in more than 50% of the cells, or when we have an intense staining, but this staining is in less than 10% of the cells. And as I said, 0 is when it's not a 1 plus or absolutely no staining. So this is the first line testing by immunohistochemistry. When we have a 3 plus, the case is considered as HER2 positive. We don't need to perform anything else. The patient is eligible to anti-HER2 therapy. If we have a 2 plus score, we need to reflex an in situ hybridization technique. And here, the scoring is also different from breast. We need to have a ratio HER2 over chromosome 17 superior or equal to 2 in 50% of the cell. And if it's a 1 plus or a 0, the patient is not eligible for an anti-HER2 therapy, and we don't perform in situ hybridization. I have to mention also here that we can have in colorectal cancer HER2 mutations. They can occur in 2 to 4% of the cases, roughly. And they are not completely exclusive from HER2 amplification, but they can also be found sometimes when we don't have HER2 amplification. And we have some cases that now can be considered as HER2 low, so exactly as we do in breast. Those cases are when they are 2+ non-amplified or 1+. And in colorectal, it's around 25% of the cases. So this is, in summary, we need to do immunohistochemistry. If we have a 3+, it's a staining in more than 50% of tumor cells. If we have a score 2+, we must reflex by FISH. The criteria for amplification is also different from breast cancer, is when the ratio HER2 over chromosome 17 is superior or equal to 2 in more than 50% of the cells. And NGS could be another methodology for testing for HER2 amplification.
Thank you, Friedrich. But how do we use then NGS when testing for HER2 positivity in clinical practice? And also related to that, could circulating DNA have a role in identifying HER2 positive patients?
Thank you, Eric. In those cases, of course, we are not looking at the protein. We will look at copy number variation at levels of DNA. So it's completely possible with NGS, and it's also completely possible with cell-free DNA. So we will evaluate the copy number of HER2 or HERB2, that is the other name of a gene. So if in the clinical practice you have access to NGS to look at KRAS, BRAF, PIK3CA, other biomarkers, the lab can also evaluate a copy number variation in HER2 and also can give you, and it's the same with liquid biopsy, can give you also whether there is or not HER2 mutation. The only thing that is important is that when you work with liquid biopsy, a negative test doesn't mean 100% that the alteration is not present. It could be a level of sensitivity of your liquid biopsy technique, because we are dealing with very low amount of tumor free DNA. So in case of a negative liquid biopsy result, especially if the patient is known to be a KRAS wild type and BRAF wild type, it's really worth to go to the tumor and to perform immunohistochemistry.
This is all very important and useful information for clinical practice. But of course, on top of that, we should look at some of the clinical data for HER2-directed therapies. We've seen many data focusing on breast cancer, many data on gastric cancer, but also in colorectal cancer. Recently, we have seen some data. It started all with the study, the Heracles study, which was done by our Italian friends and colleagues, who looked at, based on also some preclinical studies in xenografts, on the activity of trastuzumab lapatinib, and later on also pertuzumab TDM1 studies. If you look in most of these studies, there was a consistent benefit of the combination of these agents. Within most of the studies, response rates between 25 and a bit more than 30%. These were all non-randomized studies in refractory patients in later lines. And what was also nice is that in those patients with the response, there was a certain duration of the response, leading to, at least in non-randomized studies, having the impression that this could have an impact on the outcome of these patients. More recently, we have seen, and maybe Chiara, you can explain us on the important Mountaineer study and update us on this study of what it means and how the design was.
Yes, thank you, Eric. Actually, the Mountaineer trial is nowadays one of the most solid evidence we have about the usefulness of anti-HER2 strategies in metastatic colorectal cancer. This was a global multicenter phase 2 trial that enrolled pretreated metastatic colorectal cancer patients with RAS wild-type status and, of course, HER2 amplification or overexpression as per local assessment to receive a combination of anti-HER2 drugs that were the monoclonal antibody trastuzumab and the tyrosine kinase inhibitor tucatinib. Initially, all the patients were treated in the first cohort of the trial with this combination. Then an expansion cohort was set, and the patients were randomized to receive the same combination or tucatinib alone. As I previously mentioned, all the patients had to be RAS wild type, and it was allowed the assessment of HER2 by means of immunohistochemistry, in situ hybridization, or NGS, as previously mentioned and well explained by Frederic. The results with tucatinib alone were not so convincing, while the combination of the double blockade of HER2 in the external part of the cell, the extracellular domain of the receptor by means of trastuzumab, plus the intracellular inhibition by means of tucatinib, allowed to achieve interesting results in terms of objective response rate that was the primary endpoint of this study. Interestingly, according to the trial design, patients that did not achieve benefit with tucatinib alone were allowed to switch to tucatinib plus trastuzumab. Overall, 84 patients were treated with the double HER2 blockade, and the results in terms of objective response rate were a confirmed objective response rate of 38%. Considering that these patients were highly pretreated, clearly these signals of activity for the combination were quite relevant. The median progression-free survival was 8.2 months. More than 59% of patients were progression-free at 6 months. And in terms of overall survival, the median value, the median duration of overall survival was more than 24 months. The global safety profile of the combination was quite manageable. The rate of grade 3 or 4 adverse events was very low. In most cases, adverse events were of grade 1 or 2 and mainly involved gastrointestinal toxicities in terms of diarrhea or nausea and, of course, fatigue. Overall, there was a 21% of infusion-related reactions, but the treatment was quite manageable in the frame of the clinical trial.
And Chiara, is this also been taken forward now in larger phase 3 studies? There is a Mountaineer 3 study, which is in early lines. Also, can you explain us the design of?
Yes, Eric, this is really interesting because I believe that if we have found an actionable and relevant target that is a driver for tumor growth, then we want to inhibit this target as soon as possible in the patient's treatment history. And the Mountaineer 3 trial has the objective to investigate whether targeting HER2 from the very beginning in the frame of the first line of therapy is beneficial for HER2-positive and RAS wild-type metastatic colorectal cancer patients. So the Mountaineer 3 trial is a global phase 3 study that is currently enrolling patients worldwide. These patients are randomized to receive the standard of care, that is a doublet of chemotherapy, with or without a targeted agent according to the investigator choice, or the experimental treatment, which will be FOLFOX plus tucatinib plus trastuzumab. The primary endpoint of this study is progression-free survival.
Well, that study is ongoing, but we have also some data with another HER2-targeted agents, which is trastuzumab deruxtecan. This is an antibody-drug conjugate consisting of trastuzumab, then a tetrapeptide-based cleavable linker, and then a cytotoxic agent that is linked to that. That's a topoisomerase 1 inhibitor, a payload exatecan, an exatecan derivative. And with this agent in colorectal cancer, we have seen also two clinical studies, the Destiny CRC1, and then later I will explain the Destiny CRC2 study. In the first study, this was an international multi-center open label phase 2 study done by our Japanese colleagues. In this study, patients with RAS and BRAF wild type and HER2 overexpressing tumors were included, and they were assigned to three cohorts. A cohort with the classic HER2 positive tumors, as explained by Frederick. This was 53 patients. And then two small cohorts of 15 patients, with cohort B with low expressing HER2 tumors, and cohort C, 18 patients with very low HER2 expressing tumors defined as IHC1+. This was non-randomized. All patients received trastuzumab deruxtecan at a higher dose, 6.4 milligrams per kilogram every 3 weeks, and overall response rate was the primary endpoint. And if you look at the activity, there were no objective responses in cohort B and C, but there was a high response rate in cohort A, so in the HER2 positive patients with an objective response rate of 45% in this non-randomized study with 53 patients. So quite interesting data, with also a relatively long duration of response, a medium duration of response of 7 months in this study. And if you look at the progression-free survival, you can see that the same messages were given. The PFS and the OS was clearly longer in patients with a HER2 positive tumor with the criteria of IHC 3+ or IHC 2+ followed by positive ISH test, was clearly longer compared to the patients with a low or very low HER2 positive tumor, suggesting the clear impact of trastuzumab deruxtecan in this patient population. Like with any agents, there is toxicity. This is an antibody-drug conjugate. We see therefore some classic chemotherapy-related toxicities, such as hematologic toxicity, fatigue, some GI toxicity. And what is special also with this ADC is, as was reported earlier previously in breast cancer and stomach cancer, we also see some drug-related interstitial lung disease, and the drug-related adjudicated ILD or pneumonitis was in around 9% in the study. After the Destiny CRC01 study, there was the Destiny CRC02 study. This was a randomized study in the first stage, randomizing patients between the initial higher dose of 6.4 milligrams per kilogram every 3 weeks, or the lower dose that is also used in breast cancer, 5.4 milligrams per kilogram in stage 1. And then later there was a stage 2 of the study. Each group of the patients had around 40 patients. That means that in total, at a lower dose of 5.4 milligrams per kilogram, there were 82 patients included. The primary endpoint, in view of the nature of the study, was the overall response rate, and this was presented at the last ASCO meeting. If you look at the activity in the study, at the 5.4 milligram per kilogram cohort, as well in stage 1 and 2, the objective response rate was 38%. In higher dose, it was 27.5% in this study. And looking also at, and it's of course not difficult to make statements on real differences in PFS, but as you can see, they were quite similar. The shape of the curve is similar in the lower dose compared to the higher dose, with median PFS approaching 6 months. And also looking at the survival, no clear differences can be demonstrated in this setting, but median survival of more than 13 months in the lower dose cohort with 82 patients. Safety was a bit more favorable, as expected in the lower dose, with a little bit less hematologic toxicity, a little bit less GI toxicity if you look at the lower dose. And also, if you look at the interstitial lung disease or pneumonitis at the lower dose of 5.4 milligrams per kilogram, 8% of patients had any grade of ILD, and they were all grade 1 and 2, while this was slightly higher in the stage 1 part of the study at the higher dose cohort in this setting. So quite interesting data. And Chiara, there was also recently a SWOG study done. Can you update us on some of the design and some of the data of the SWOG study?
Yes, this is interesting because actually this is the first randomized trial comparing in the HER2-positive population an anti-HER2 strategy, that is in this case trastuzumab plus pertuzumab with a potential standard of care, which is cetuximab plus irinotecan. Actually, the trial failed to meet its primary endpoint, that was progression-free survival, but I think it's worth mentioning the results of this trial because when looking at the results by mean of in situ hybridization, the highest was the ratio between HER2 copy numbers and the centromer of chromosome 17, where actually HER2 gene is located. There is a clear benefit from the anti-HER2 strategy only in the subgroup with a ratio higher than 5. This means that probably according to the different anti-HER2 strategies that we are studying right now in clinical trials and we will be allowed to use in the next future in our daily clinical practice, we need also a lot of research about how to best identify HER2-positive patients that may actually derive benefit from these different anti-HER2 strategies.
Let's illustrate all this knowledge of data with a case, Chiara, that you have prepared. Is maybe you can explain us what was the fate of the patient and the case of the patient?
Thank you, Eric. It's very simple. This is a case that came immediately to my mind when thinking about HER2-positive metastatic colorectal cancer. She's a female. At the time of diagnosis, she was 62 years old, an English teacher with no relevant comorbidities in her personal history. The diagnosis was performed in January 2020, and after bleeding, an intraperitoneal rectal cancer with synchronous liver and bilateral lung metastasis was actually diagnosed. So apparently quite aggressive disease, synchronous metastatic disease. The colonoscopy and the biopsy were performed and revealed an adenocarcinoma. The molecular analysis that were performed revealed the expression of all the mismatch repair proteins, so it was a proficient mismatch repair case. RAS and BRAF were wild type, and HER2 was positive. The immunohistochemistry had a positivity with a score of 3+. So this was a case of left-sided primary tumor, RAS and BRAF wild type. In these cases, in our daily clinical practice in my center, we generally test HER2 to exclude the anti-EGFR treatment in the case of HER2 positivity. So this was the case, and we decided to start the first-line therapy according to the FOLFOXIRI plus bevacizumab regimen. The patient was in very good general condition, and based on the HER2 positivity, we decided not to use an anti-EGFR as part of her first-line therapy.
Yeah, Frederick, this brings a question for you also. If this patient, as Chiara said, is IHC 3+, Is it still useful to do an ISH test in this type of patients? And the second question is, do you support the idea that we test immediately at the diagnosis of metastasis, or would you reserve that for later lines at HER2 testing?
So here the patient is 3+, so when we have this very strong membrane staining, it's not questionable, so the patient don't need to have a confirmation by ISH, first point. Second point, I think, as Chiara said, it's very important to have the information as early as possible at the metastatic stage, because it will have an impact on the treatment with anti-EGFR therapy, because it's really known that the HER2 amplified cases are, it's a marker of resistance to anti-EGFR therapy, so as early as possible.
And then, Chiara, coming back to your patient, if the patient progresses at a certain moment with liver and lung metastasis after FOLFOXIRI bevacizumab, what would be your recommendation for further treatment, and or how would you approach that?
Actually, these patients achieved the benefit from FOLFOXIRI plus bevacizumab with a good partial response, and then received the maintenance with the 5FU and bevacizumab, and had a progression-free survival to the first line of 14 months. Then actually disease progression occurred. In this situation, I think that having an anti-HER2 strategy available, I could try to put in place this targeted action as soon as possible in the patient's treatment history. So in this case, both chemo and anti-angiogenic agent, maybe also the use of the anti-EGFR, could be options based on the clinical guidelines, on the current guidelines, but I could bet on the anti-HER2 strategy as soon as possible in the continuum of care of this patient. And actually, this was our choice also in the clinical practice.
And just a couple of words, how is the tolerance of tucatinib and tucatinib trastuzumab in general, and what's your experience, Chiara?
My experience was pretty good. The most relevant toxicities were gastrointestinal, but of very low grade and so easily manageable in a proactive way by telling patients not to wait too much before referring these adverse events and stopping diarrhea as soon as possible with loperamide or other recommendations.
And suppose that this patient becomes progressive on trastuzumab tucatinib, and that the question is also then for Friedrich, would you retest at that moment again for HER2 in this setting to look at eventually for other HER2 targeted therapies such as trastuzumab deruxtecan? Maybe Friedrich, what's your position on this?
Yes, I think when it's possible, it's better to retest, because sometimes also the HER2 amplified part could have of the tumor could have disappeared, so the tumor could become HER2 negative. So I would be interested in looking at the tumor, looking whether we have if it's HER2 negative but it's HER2 low. So yes, I would retest the tumor and re-examine the biomarkers. It could be also a liquid biopsy test to see if we have some mutation that appear like BRAF or KRAS.
And Chiara, final question on your patient. If the patient is progressive, and suppose that Friedrich is retested and the patient is HER2 positive, would you consider in that situation trastuzumab deruxtecan? Would you say, let's go first to an anti-EGFR targeted agent, or would you say not one of these is an option, and we'll go for trifluridine diprasil with bevacizumab, for instance.
Well, Erika, I think that maybe trastuzumab deruxtecan could be the best approach, but right now we do not have such a solid evidence about the usefulness of this treatment option. Yes, in the Destiny CRC 01 and 02, also the previous treatment with an anti-HER2 strategy was allowed, and the benefit from the antibody drug conjugates seems there independently of the prior exposure to the anti-HER2 strategy, but these were not randomized trials, and so the level of evidence for this approach is not so high, and today in my daily clinical practice I am not allowed to go for this strategy. Following tucatinib plus trastuzumab, I would rather go for a standard treatment option. In this case, we administered capox plus bevacizumab and then trifluridine tipiracil plus bevacizumab. I am not a believer in the role of anti-GFRs in this molecular subgroup, although in later lines of therapy, it's something we can still take into consideration.
Thank you. So as you can hear, there's so much information. Our knowledge is really rapidly evolving. And I think it's fair to conclude that HER2 targeted therapy is an established becomes an established therapy in metastatic colorectal cancers who are HER2 positive. It's a low number of patients, but it's an important group, and it's good that our therapeutic armamentarium has increased with different options in this setting. We will have to do strategic studies, and so many open questions. We have to learn a little bit more on the tumor biology in this setting. But over the last couple of years, with the data that we all three presented to you, we have made clearly progress. So thank you very much, Chiara and Frederick, for sharing your insights. And thank you to all of you, especially for listening to us to learn more about important progresses in colorectal cancer.
This program was presented by Medscape Education Global.